Okay, good afternoon. My name is Nathan Schneider, and I went to the University of Cincinnati. And this study I'm going to present is the Dosimetry of Craniospinal Axis Irradiation. It's a comparison of conventional and helical tomotherapy-based treatment plans. So let's get started. The objective of this study was to measure and compare the integral dose to critical structures from the whole body craniospinal irradiation using two different radiation delivery modalities. As mentioned earlier, the two modalities were the conventional variant linear accelerator and the helical tomotherapy. The specifics of the delivery modalities: the conventional uses two laterally opposed cranial fields with a single posterior field, and that was accomplished on a barium EX with 6 MV photons, excuse me. The helical delivery, the helical treatment plan was developed in result so that the PTV, dose volume histogram, was clinically acceptable. That deals with treatment times, beam modulation, gantry rotations, what was mentioned earlier. Now, structures of interest that were contoured: the heart, both lungs, esophagus, stomach, both kidneys, bowel, the liver, breasts, oral cavity, parotid, thyroid, brain. I also forgot the spleen. The spleen was contoured as well. The materials used were the Pinnacle treatment planning system, the Varian linear accelerator. I used Brain Lab for identical contouring. I used the Tomo treatment planning system. I used the Tomo accelerator, and I used a Rando Phantom with breast attachments. And here's a picture of that. So the way this happened, the method of all this was first I CT simmed the Rando Phantom on a Siemens sensation. I did it in both prone and supine, about 120 images each, and those were 8mm slice thicknesses due to the data input restrictions of tomotherapy. The contouring, the PTVs, and the treatment volume for the integral dose. You could define the PTV as the cranial region and the whole spinal cord. The goal of inhomogeneity to 36 gray to the PTV was what we were going for. We developed treatment plans for both the conventional and the helical techniques, and then finally we analyzed the integral dose delivered to the Rando Phantom. Now this is a contour of the Rando Phantom, the organs in them, on Brain Lab. This was done with image fusion of actually a real patient, CTs as well. It's a pediatric patient. So the treatment planning, following contouring image fusion treatment planning commenced on both the Pinnacle ADAC and the tomotherapy treatment planning system. Same contours as I mentioned earlier were used on both. We were again looking for reasonable treatment times on the tomotherapy unit, and the only difference was the prone and supine positions. Now this is a screen capture of the Tomo showing that there is 36 gray to 95% of the PTV. This is the way we normally see them in cumulative dose. For this study, I actually looked at the differential mode, and if you'll notice, the y-axis is the absolute volume of the organs. It's in cc's. And then this is the ADAC screen capture of the same differential modes. So now if we look at the actual integral doses for the PTV, up there in the right corner, you can see that the conventional and the helical are relatively the same integral doses at 47.32 or 47.46. Now if we take a closer look at the bowel, you can see that the helical TomoTherapy delivers a higher integral dose at 33.35 versus the conventional, which would be 26.62. Now, if you look at the breasts, you can see that the helical delivers a higher integral dose. And if you actually visualize this, this would be because the breasts are not in the posterior field. And Tomo actually does a better job at sculpting around those organs. Here's the esophagus. Okay, and here's the heart. Now the heart would be in that posterior field, and so therefore it would be getting more integral dose from your conventional, the three-field technique. And so it is getting 8.37, while the helical's integral dose would be 2.68. So on this specific organ, the helical TomoTherapy would deliver a total lower integral dose. Now if you're talking about the lungs, the helical gives a larger integral dose than does the conventional. And now the stomach. So TomoTherapy can actually deliver a lower integral dose to the stomach. If you look at these graphs, the area under those graphs, if you integrate that, that is what is defined as the integral dose. And coming up, I'm not going to summarize all this. There's the thyroid. So the external skin, this is the total whole body dose. We call that external skin. It's everything from your skin in. The helical TomoTherapy delivers 390.37, and the conventional delivers 355.31. So therefore, you could say it's safe that the Tomo delivers a higher overall integral dose. Here's all these numbers on one sheet. It's pretty crowded. The two middle columns, there's no units on those. Those would be joules. And if we take a minute, you might see like the parotid, for example, they're actually both the same. If you look at the testes, those are actually too small. So we got no measurements. The bottom line is the sum of all that, and the total percent difference is 9.8% higher integral dose on the TomoTherapy. So for future outlook, I'd like to crunch some numbers. I want to look at the biological effective dose, which is the principle of cell survival curves having the same biological endpoint. Looking more closely at the alpha-beta ratios, as we talked about earlier this morning, with respect to late reacting and early responding tumor cells. Also, might look at the equivalent uniform dose. I'm not quite sure on that. We can talk about that if anybody's interested. I'd love to. And then the risk of secondary malignancies would be quite fascinating as well. That's about it.
Thank you very much. If Dr. Young can also come up to the stage, and if any questions for the both of them, please raise your hand. We'll have a microphone brought to your area for you to ask questions. Any questions? If not, let me ask Dr. Young a question. That you mentioned that there's 45 minutes of planning time per case. Does it include the overnight crunching?
No, actually, it doesn't include. Actually, you can specify the dose constraint and then you achieve the target. It's very simple structure. So you just define a GTV, and you can run it 45 minutes to get a preliminary results. Right. Yeah, you don't have to go to the fine calc for the overnight for this type of cases. Yeah. If you really want to fine tune it to the level that really fine, and then you might have to do that. But in general, 45 minutes you can actually come out of plan that was acceptable for treatments. It was pretty decent compared to conventional treatment.
Thank you. I have a question for Mr. Schneider too. You mentioned your next project would be on the RBE studies. Do you have any reason to expect that there would be differences between the two?
That's a great question. Actually, no, I don't, but I feel like it would be good follow-up.
Right, thank you. Any other questions? If not, then thank you very much. The next speaker is Joe Ho. Great.